The first speaker, Naoki Nakashima, from Kyushu University Hospitals. Naoki Nakashima, MD, PhD, is an associate professor in the Medical Information Center, the chief of the International Medical Relations Office in Kyushu University Hospital. He has been a specialist of diabetes mellitus for 20 years and simultaneously worked of Japanese Society of Diabetes Mellitus and the director of the Scientific Committee of Japan Association for Medical Informatics. He focuses on the disease management methodology to prevent chronic disease as diabetic mellitus and complications. He has organized the Karuna project, which aims to establish a Japanese model for disease management of diabetes mellitus from primary to tertiary prevention as a social system. From 2012, he started a health checkup and a remote medicine project for 10,000, a really very huge number, citizens or more in Bangladesh as a variant model of disease management. He is also a founding member of a Telemedical Development Center of Asia, which we call the TEMDEC, in Kyushu University, which promotes broadband telemedical network in Asia-Pacific area. TEMDEC is the most active institute for international telemedicine in Asia-Pacific area. He is going to speak portable health clinic, a remote medicine trial in developing countries. Dr. Nakashima, please go on.
Thank you very much, Professor Yansley. Next time, I want to shorten my profile. Thank you very much. Anyway, so I want to talk about this portable health screening. Can you see my slide?
Yes.
Yeah.
Now,
yes, okay.
Please go ahead.
My talk is a portable health clinic, a remote medicine trial in developing countries. As the activity of Telemedicine Development Center of Asia, TEMDEC, in Kyushu University. I'm working with Professor Shimizu for 10 years. This is my study partner in Bangladesh, the Grameen Communications. The Grameen Group is very famous for the microcredit to support self-sustainability for female in village. And Professor Yunus won Nobel Peace Prize in 2006. And Kyushu University, they collaborate with Grameen Group from 2007. This is Bangladesh. This is Bangladesh map. So Bangladesh has really high population and density, but 70% people are living in rural areas. So, but in rural area, there is very poor healthcare facilities in village. So, many people cannot access health facilities and health institutes. But I would show this Bangladesh infrastructure. Right now, mobile network is spreading about 98% of national territory as other developing countries. And but no doctors. There are no doctors in village, but many pharmacies in any village. This is very special in Bangladesh. And this medicine is very good medicine. These are generic, but these are very cheap. So I think this tele-prescription from Dhaka, capital Dhaka, should work in Bangladesh. And I want to introduce about portable health screen, PHC. This is Grameen medical lady. So she can bring this attached case with a lot of sensor devices and Android terminal. All tools sensors are then body area network enabled for direct data transmission to online online server for remote doctors in Dhaka. These are the sensor devices: body temperature and blood pressure, this one, and pulse rate, and arrhythmia, and height, weight, and BMI scale, and waist hip ratio, and oxygenation in blood, and blood glucose, and hemoglobin concentration, hemoglobin, and urine sugar, urine protein, low nausea in urine, and ECG. This is optional, and actually telemedicine by specialized call center in doctors in Dhaka. This is 3 years of the portable health clinic project. First, we conduct a health checkup by these sensor devices, and we stratify 4 colors: green, yellow, orange, red. Yellow is subnormal or cautious, and red is affected, abnormal, and red is emergent or serious ill. And we provide telemedicine service for the orange and red subjects from Dhaka call center. This is actual scene of telemedicine. This is patient in rural area, and this is call center. Bangladesh is Islamic country, and then women don't want to see a male doctor, so we have to prepare male doctor and female doctor also. This is very special in Islamic country. And this is, we call B-logic, Bangladesh logic, to make the triage, make the subject 4 colors. This is established by the international standard criteria. And this is questionnaire sheets for the every subject. We have the sheets for first visit and for second visit, and we made this in English and Bengali also. This is the booklet of healthcare guidance. We use these for yellow and orange and red subjects. This is also written in Bengali and including the food in Bengal, Bangladesh. This is just scene of the step. First, this is patient registration and case history collection. And then the subjects get the health checkup. And then we can provide, stratify the subject into 4 colors. And orange and red, we provide the telemedicine from Dhaka. This is female doctors. And finally, we provide a report and prescription to the patient, orange and red. This is a user interface in the portable health clinic. This is a list of patients, red color list. And these are the personal report of the health checkup, and this is for the telemedicine report and prescription also. This is the data of this 2 years. We have more than 10 health checkup places in Bangladesh, in urban site and rural site and suburban site. Urban site means the factory. We made a lot of health checkup in factories, and these people are living in Dhaka, big city, and rural means a village, and suburban means the factory, but they are living in village. Okay. We conducted a total of about 15,000 subjects, health checker, for 2 years. This is the result of sex in the area. In rural area, we have a lot of subjects and female dominant. In suburban and urban area, we have the male dominant. This is the result of each sensor devices. We have a lot of yellow patients subjects in waist-hip ratio in Bangladesh and also BMI. That means there are a lot of obese subjects in Bangladesh already, and there are a lot of high blood pressure. I mean hypertension. Actually, orange patients, and diabetes is not so much, but still there are red emergent patients in here. And amazingly, we have in Bangladesh they have a lot of urine protein subjects. This is much more than Japan. So total, this is the total color. I mean if green, all green is just green. So green, orange, green. So it's orange. I mean the worst color is the final color, total color. So yellow is the most dominant color in this total subject. This is age distribution of subjects, and of course younger subjects is healthier, and elder subjects is a little bit unhealthier. We double check the orange and red subjects 2 months later because we provide telemedicine and teleprescription, so we have to check 2 months later. So, but in that, you can see this. This is the first visit, and this is the second visit after 2 months. 55% subjects improve the color. Okay. This is orange subject, and this is red subject. Both colors improve the color. This is second year. So this is first fiscal year 2012, and this is next second year. This is also same tendency. And in rural area, we have a lot of female subjects, but a little bit aged subjects. So that is why in rural area the healthy situation is not very good compared to urban and suburban. This is younger subject. And this is the comparison with Japanese data. In the data of 2012, Japanese data is 2,000 and 8,500 subjects. Amazingly, so urine protein is much in Bangladesh compared to Japan. You can see. So obesity is almost same. Blood pressure is a little bit higher in Japan, and blood sugar is a little bit higher in Bangladesh. This is also a little bit amazing because Bangladesh has a little bit high, almost same BMI with Japanese subjects. But urine protein is much more than Japanese subjects. That, this means Bangladesh subjects has high percent of chronic kidney disease, renal disease, CKD. And this is urine protein distribution varied. This is varied among sites. In Japan, 90% 95% is green, but this Shuyatku, we can see a lot of green subjects, but in Takurugaon, we can see the orange, a lot of orange. This is urine protein plus, and this is urine protein plus minus. This is urine protein minus. So, and Rashahi also high percentage of the urine protein, and Chitagon and Eclaspur also. We guess this is caused by cadmium kidney damage. Maybe cadmium is contaminated in the river water or something. Because a recent paper showed rice and vegetables are contaminated by cadmium in Bangladesh. Now we are investigating this kind of cadmium concentration or cadmium contamination in Bangladesh. This is a change of blood pressure between fiscal year 2012 and next year. And just this is green, yellow, orange, and red subjects. In every curve, the blood pressure improved in the next year after the health checkup and telemedicine. This is blood sugar. Blood sugar also improved significantly in orange and red patients. Maybe they got prescription of the diabetes mellitus. This is the photograph of the Global Social Business Summit in Malaysia 3 months ago. This is Malaysian Prime Minister Najib Razak, and he is Professor Yunus in Grameen groups, and this is my students we sent from Kyushu University. They are explaining this PhD to the Prime Minister. And we are thinking this same system can be used in the right after disasters, because the situation is really similar in the disaster side. A lot of stress and a lot of chronic disease patients in the evacuation center. We can know how the situation of the blood pressure and blood glucose in this patient in the this site, and we can provide advice from telemedicine center in Kyushu University. And in the future, we are planning to establish a home care medical system by very similar system. This is a high-risk patient at home, and he can have a lot of sensor devices at home, and we can send the data to data center. And this is future work. We are now making the caravan model by the team of nursing staff and engineering staff. But from next year, I mean the fiscal year 2014, we can add a clinic model. We fix the clinic in the village. Okay, so we can have 2 models. And we want to use this system for the right after a big disaster. And we also expect this system is applicable for management of chronic disease or AIDS subjects at home. Thank you for your attention. Thank you very much.
Okay, thank you, Dr. Nakashima. I have a question. What is the main difference between Karuna model and the clinic model?
This is the same model. This is also Karuna model, because we certify the whole subject. First, we health check up the whole population, and then we certify the subject in the 2, 3, 4 colors, right? And we invest a lot of cost in the high risk group. Okay, and then we check right after we check the population regularly. So this is same model to the partner project, but the
Okay.
place is different.
Okay, thank you. And another question is, how do you get the data from the Bangladesh patient to your Kyushu center? Automatically through the web-based data gathering system do you have, or just physically every data after collected all the urine or blood sugar and the blood pressure level the data, and then you delivered the data to Kyushu University? How do you communicate?
All data are collected in data center, but we have backup center. And in Kyushu University, this backup center has no name, I mean anonymous data only. But in data center, there is a name, personal name. So it's a little bit different.
Okay, so is there any question from the other side? Because Dr. Nakashima is going to leave due to his timetable, so this is the last question for him. Dr. Nakashima, you mentioned about the portable box. So is it commercially available, or available? How much it is?
You mean PHC, right? Attached case.
Yeah, portable box.
Portable, yeah. That's $10,000. $10,000
US dollar in each box.
Yeah, but we use the all Japanese device. We can reduce the cost if we use the different device.
So how many device at the box? How many device is there at the box? So how many kinds of sensor do you have?
Yeah. I already show you. We can check the 14 kind of the sensor data. 14. You can see my slide.
Yeah. Okay. Yeah. Very fantastic. 14. 14. Yeah. 14 sensors you have. It's very fantastic. In my knowledge, this is the new one and most of vast sensor you have.
I'm sorry, I have one mistake. We add this hemoglobin sensor. This is the sensor of the anemia. This is a little bit expensive because this is new version. Old version has no hemoglobin. But in Bangladesh and these countries, a lot of anemic subjects in young lady who may deliver in the year. So now we are checking the hemoglobin concentration, and if we find severe anemia, we are now providing the tablets of iron, and they are recovering.
Okay. Thank you, Dr. Nakashima, again for your participation due to your busy schedule. Okay, thank you, Dr.